The topic here is a definite hotbed of activity. There's no doubt that there are strong opinions given this title on the pro and on the negative. I'm going to give a disclaimer that this is my take on this topic, so I'm going to do my best to not require any Kevlar or bulletproof vests afterwards from those of you who may feel differently than me. But we have a lot of time for discussion afterwards, and we would welcome your debate once we have laid out some of the facts here ahead of time. I have no disclosures for this discussion that would create bias, but I do have to disclose that Andrew Bolton, although not currently in the room, will be here shortly. And I'm very scared of Andrew Bolton because he's a powerful man and very strong from UK. He feels very strongly on one opinion, which thankfully, after doing the research, I would have to say I agree with most of his opinions. So that definitely biased my talk towards the direction, knowing that Andrew Bolton was going to be critiquing afterwards. It is important to understand that coming events cast their shadows before. Thomas Campbell shared this quote, and this is indeed a photograph of my partner, Chris Addinger, seated to my right, performing a below-knee amputation on a patient that we failed on. And we all know and have had healthy, great discussions about the fact whether or not amputation is a failure, as we know that it is certain victory for many of our patients for regaining their life. But we all have many stories that we would share where we felt things could have gone differently, and whether that blame is laid on the patient for their compliance or failure to embrace the therapy choices, or whether that blame is laid upon us as their providers for not offering them the right choices, or perhaps not being as emphatic as perhaps we thought we could have with patient education. A lot of debates here about the fact of whether it's truly non-compliance to care or failure of the provider to educate the patient. And this topic of neuropathy that we're looking at right now, I think, is very relevant to those words because it's silent, it's painless, and the patients, as well as sometimes us as the providers, are happy to ignore it until we reach grave consequences. So I'm a pretty simplistic practitioner, and I have a pretty simplistic way of approaching academics, and if you were to try and oversimplify diabetes onto one slide, you could say that it's all vascular disease, and it's all either microvascular or macrovascular. So I have oversimplified the entire disease process, probably to a great degree of error. But if you were to break that down into these two categories, one of the key and significant factors of microvascular disease is neuropathy, and we will be debating some of the end products of that during these next few moments. The consensus definition published in 1998 in Diabetes Medicine says that diabetic peripheral neuropathy is the presence of symptoms and or signs of peripheral neuropathy nerve dysfunction in people with diabetes after the exclusion of other causes. Very, very difficult to put our finger and do a diagnostic test to say that this nerve and sensory loss or motor loss is directly attributable to diabetes. We know it when we see it, but it's very hard to be objective about it. So I think this quote and this consensus definition does help to some degree because it reminds us that we have to first and always exclude other potential causes that would need completely different treatment than assuming that it's diabetic peripheral neuropathy. So while most times it's probably correct to assume that what you're dealing with is DPN, we have to still be a provider and a thinker and realize that it could be something else and rule that out first. So neurological assessment, very straightforward, and most of us carry Sims-Weinstein monofilaments around in our pockets, or if not, you have them in the top drawer of your clinic exam room, and we're very proud and quick to use that as our screening tool. But this is not where the neurologic examination should stop in your patient with diabetes. Sensory neuropathy is, of course, the focus of this discussion and the focus of the title that I was assigned, but it's important in this context to keep in mind motor neuropathy and autonomic neuropathy. Motor neuropathy, which can have a significant mechanical and biomechanical impact to the diabetic lower extremity, is a very important segment of this neuropathic disease and can be very much affected with or without the sensory loss in many of our patients. So evaluate your patients for motor function, particularly when you're looking to perform a surgical procedure or intervention that may require tendon transfer, tendon lengthening, tenotomies. You have to know what are the end products of the neuropathy in other aspects of the motor disease. The other autonomic neuropathy certainly would affect your healing potential, the skin incision placement, your care afterwards, and the overall risk evaluation of that patient for surgery. So this is the patient that we are really challenged with dealing. The title of this talk talks about using nerve decompression surgery for ulcer healing, and that's certainly part of it, but wouldn't it be even better if we could have this neuropathic patient who is having the pre-ulcerative changes and do surgery to fix that and to restore their sensation, restore this pain that they have lost so that they would perhaps walk differently, and that perhaps they would have restored motor function if we were able to alter that pathway as well. This photo is a little later in the disease state, right? So now we have not only callus, neuropathy, and deformity, but we have bleeding into the callus. So we have enough tissue pressure to cause a break in the skin. And this is one of those patients that we educate our students and residents on very emphatically in conference. Matter of fact, we just talked about this a couple weeks ago at Georgetown, about this is the exact patient who comes in for their initial diabetic foot examination. And after you've assessed them, what's the first thing you're going to grab from your assistant? A number 10 blade, because you've got to debride that. No diabetic foot provider could allow that to leave the room without debriding that. It's physically impossible for us to allow that patient to leave the room. We must debride that. And that's great. That's a healthy and correct emotion. But if you don't educate that person initially, before you debride that, you're going to get a letter from their lawyer, because their interpretation, if you haven't had that conversation with them yet, their interpretation is, I went to go see Steinberg, I had this numbness and I had a callus, he cut the callus too deep and now I have an ulcer. Happens routinely in the medical malpractice world, where good providers get wrongly blamed for causing an ulcer because they cut a callus too deep. So patient education starts with the very first visit, and it starts before you grab the blade, and particularly in this particular scenario of this snapshot in time for this particular patient setting. This is a patient from our San Antonio Diabetic High-Risk Foot Clinic that came in for routine follow-up, quarterly high-risk foot examination and evaluation. This was not an urgent visit. This was not an ER picture. This is a picture from Clinic Exam Room 3 at the Texas Diabetes Institute for a patient that came in for his every 3 to 4 month checkup to see how his feet were doing. He was wearing shoes. He was wearing socks. He had no idea that he had a nail in his foot. And you laugh at that, or you say, Steinberg's showing silly pictures here that don't make sense anymore. But this patient has neuropathy. This patient has limited joint mobility. He can't get down and reach his feet. This patient has significant retinopathy, so visual impairment. He's missing all the warning signs that would have told him that he has something grossly wrong with his foot. So the signs and symptoms of diabetic peripheral neuropathy, obviously the symptoms, numbness, tingling, burning, aching, lancinating pain, allodynia, these are all the realities of what we deal with in the symptoms. Welcome, Dr. Bolton. We gave a proper introduction to you earlier. We'll need your comments later. The signs of diabetic peripheral neuropathy are diminished vibratory perception, decreased knee and ankle reflexes, obviously significant protective sensation that we've talked about earlier, and the diminished proprioception. These are all fairly straightforward, run-of-the-mill neuropathic examinations and terms that we talk about rather routinely. So we know from Dr. Bolton's work and others published extensively that this multiple metabolic pathways for how this diabetic polyneuropathy or lower extremity neuropathy and sensory loss can take effect. We know that this involves oxidative stress, polyol pathway, glycation that results in direct neurotoxicity, that directs in vasculopathy and ischemia to the nerve that directly impacts diabetic neuropathy, both from a sensory, motor, and autonomic pathway. So again, I opened up the talk by saying that I'm a relatively simplistic practitioner, and this diagram, which really, again, oversimplifies the disease to an extraordinary amount, if we start at the 9 o'clock position and realize that this is where we're at for high foot pressure, limited joint mobility in the face of neuropathy, that these individuals in the face of having callus or trauma buildup are going to progress on to a state of ulceration, and in the face of vascular disease, that ulcer will fail to heal, become infected, and result in an amputation. So the treatment of diabetic peripheral neuropathy, first off, as we talked about, need to rule out other causes. Don't assume that this is from diabetes. It could be from something much worse. It could be from something much more easily treated. So do your homework, practice good medicine, and determine the proper etiology of the disease, leaving DPN as the almost diagnosis of exclusion. In the assumption that it is DPN, we must stabilize their glycemic control. This is, of course, the starting point for most diabetic foot treatment. We must realize that we're going to treat essentially symptoms of this disease, but not necessarily reverse nerve damage. Pain relief is oftentimes incomplete from these individuals from medical treatment. Side effects from the medical treatment of painful diabetic neuropathy can be significantly limiting, and therefore there has been a significant movement to introduce surgery for these individuals instead of a medical management. The proposed surgical approach, pioneered and published and discussed widely by Lee Dellon and in the Baltimore area, Ivan Ducic at our institution at Georgetown. This has been widely debated and widely published, but the essentials of this, although can be involving much more, the essentials are that it is 4 medial ankle tunnels that are decompressed. You can see these are anatomically laid out, essentially following the tibial nerve distally as it branches underneath the medial aspect of the calcaneus and making sure that each of these potential pinch points is relieved. Dellon published in Plastic and Reconstructive Surgery Journal in 2000 the results of decompression of peripheral nerves in diabetics, prospective blinded study, 20 consecutive patients with symptomatic diabetic neuropathy. Mean duration of diabetes was 14 years. 31 nerves overall were decompressed. They looked at 2-point discrimination with Tinel's sign being their key marker for surgery and follow-up for their results. This, as you will see as a common theme, is a point of great concern in all of these studies of whether or not Tinel's sign is a valid marker for this disease process and for the follow-up and evaluation and judging success of their studies. The follow-up postoperatively approximately 23 months. They claimed approximately 70% of lower extremity nerves were improved with their sensibility. Ivan Ducic followed in 2006, publishing the Annals of Plastic Surgery, again looking at those 4 anatomic medial ankle tunnels that were decompressed, published on a series of patients that had diabetes, claimed improved sensibility, balance, and sway, further concluded that he was able to restore sensation, relieve pain, prevent ulceration, and prevent amputation. Ivan Ducic also discussed the theory and discussion of the double crush hypothesis, saying that the first crush or injury to the nerve was a metabolic derangement directly resultant from their disease state of diabetes, and the second crush was a physical chronic compression from the anatomic tunnels, with concern that we could at least relieve the second crush by decompressing the physical anatomy. Published by Dellon in 2012, Journal of Reconstructive Microsurgery, the results from a follow-up study in his technique looked at recurrent ulceration rates and repeat hospital admission rates that were extremely low and claimed the ability to prevent ulceration and decrease hospitalization. So the debate begins with some literature that has been put out there and has been published and some claimed clinical success. And the question now is, how do we interpret this, how do we digest this, and what do we make of it in our practices? There are a wide number of papers on this topic. Again, most, if not all of them, use as their reference point the Tinel sign. And the quotation from Lee Dellon is that patients with diabetic neuropathy who also have a superimposed chronic nerve compression demonstrated by positive Tinel sign can anticipate clinical improvement following neurolysis of those entrapped nerves. In contrast, Aaron Vinnick, widely known expert in diabetic neuropathy at Norfolk, Virginia, published also in Discussions in Diabetes Care, looking at the fact that Tinel's sign yields as many false positives and false negative results and cannot be relied on to distinguish entrapment from common diabetic neuropathy. He claimed also concern over placebo effect and the natural history of the disease that may have given falsely encouraging results from the studies, and states that this should be reserved for patients with entrapment proven by nerve conduction studies rather than the 2-point PSSD testing and the Tinel sign. The American Academy of Neurology published a practice advisory, which still stands on their website. I think the most recent date now is 2008 instead of 2006. But they state that given the current evidence available, this treatment alternative should be considered unproven. Now, we certainly have somewhat of certainly a concerning statement in front of us, but we also probably, if we looked at many of our surgical procedures, could say that about many of the procedures we perform in the operating room on a regular basis. The Cochrane Library, still standing on their website, most recent date of 2008, states that the role of decompressive surgery for diabetic symmetrical distal neuropathy is unproven, based on their analysis of the available data. So I've shared with you some of the data, and I've shared with you some of the questions, and my personal take on this, since I promised you some personal opinion, is that decompression of nerves in patients with diabetes and neuropathy can greatly reduce their pain symptoms, but I have not seen a lasting or significant benefit to sensory restoration. And I think that's where the challenge of this procedure comes, is that we need better data. We need true randomized controlled prospective trials that would have to prove to us, I think the burden of evidence still remains on the surgeons that are promoting this technique, to prove to us that this is a procedure that can restore sensation. There are significant debates, of which I'm sure we'll hear some questions afterwards. I will share with you, though, that how do we prevent something like this in this progression state? This is the disease state, this is the challenge clinically that we are all faced with that drives us to want to look for other procedures. We want to do more for this patient than watch them fail. We have significant deformity, perhaps we can correct that. But if we could combine that with an ability to restore sensation, well, that's tremendous. We all would want that. But at this time, that has not been successful. So of the reported risk factors for ulcerations, the ones that we can surgically fix are circled for you here. We can address vascular disease, we can address limited joint mobility and foot deformity, and we can address abnormal foot pressures, but we cannot fix peripheral sensory neuropathy with surgery. We can be more precise with our treatment and management of sensory neuropathy and sensory loss in patients with diabetes. We can do a better job with shoes and inserts, as you can see here, from total contact insoles taken with in-shoe pressure analysis. This is a potentially life-changing, limb-saving modality for this patient. The simple aspect of putting them in the right shoes and the right inserts in this individual could make all the difference in the world. We can prescribe and aggressively pursue prophylactic surgery for patients with diabetes, and many of these procedures now have emerging levels of evidence to show, such as one we discussed this morning, being the tendo Achilles lengthening for patients like this. Significant equinus, significant foot deformity, long history of ulceration. We can address the functional, mechanical, and biological concerns of the weight-bearing status of these individuals, so we can address their structural deformity through surgery. It is imperative that we have a team and that we approach this from an aggressive, open-minded, non-ego-based team approach if we're going to have successful results in our patients with diabetes and peripheral sensory neuropathy. This is another photo from San Antonio High-Risk Foot Clinic, and you can see this patient literally did walk into the clinic asking why their foot was making a clicking sound when they walked barefoot on the kitchen floor. And the conclusive diagnostic evidence here is that the Miller Lite beer bottle cap that is implanted on the plantar aspect of the forefoot was the definitive cause of that clicking sound. But we can practice evidence-based medicine, and we do every day, and hopefully we can continue to strive to practice even further levels of evidence-based medicine. And I'll leave you on one note of levity here, that although it's very popular to blame the patient, and sometimes there is reason to blame the patient, we have to realize that this is a very challenged patient population. And this slide is both sad and funny at the same time, because this is a piece of paper that was handed to me by one of my patients who came in complaining of multiple foot symptoms. And I said, well, can you describe what it is that you're here for me to help you with today? And the patient pulled out this folded piece of paper from the pocket and handed it to me. And you can see that apparently what I, as their podiatrist, have been charged with fixing involves their brain, involves apparently some type of dental and mental modality, penmanship, hearing concern, knee concern, pain and swelling, as well as some problem with urine passing. That's a little more than I can do in a 15-minute follow-up visit in the high-risk diabetic foot clinic. But it does describe to you just what it is that we're dealing with in this patient population. This is a challenged patient population. We have limited resources for what we can do. I think it's natural that we, as an oftentimes surgical-based approach to the diabetic foot, are striving to do more for these individuals. But I think at this point, to answer the question of the title that I was posed, I would say that the evidence is insufficient to support surgical nerve decompression for sensory restoration. Thank you very much.